them are active participants and will help you directly or indirectly, but all of them have great expertise to share with you. I'll introduce the three of them with a short bio, bring them to the table after that. They will start by explaining their points of view on important issues within the Affordable Care Act for 15 or 20 minutes. When their three presentations are done, we'll open the floor for discussion and or questions. Since there are so many of us and we on occasion have been known to be less than orderly, I'll appreciate that the questions will go through me and I'll pass them on to the panelists. If you have a specific question for a specific panelist, you can ask that of me and I'll make sure that happens. I'll ask you, in the interest of time, to make your questions succinct and cover one point and one point only in each question. The first of our panelists is Michelle McEwen. She has been president and CEO of Spear Memorial Hospital since 2000. We all know Spear as our local mid to small size hospital. It's a nonprofit hospital. In that role as CEO, she is where the buck stops. All of the functions of the hospital ultimately report through her. And her career has also included stints of Vice President of Finance for the New Hampshire Hospital Association and manager for a well-known, accounting firm, Ernst & Whinney. In addition to Michelle, we have Tyler Brennan. He is the health policy analyst for the New Hampshire Insurance Department. And he's responsible for performing health services research and providing policy recommendations to the insurance commissioner. He does this on issues related to both federal and state health insurance reform, healthcare cost transparency initiatives, and projects impacting the healthcare delivery system in New Hampshire. And he acts as the department's spokesperson and primary representative to the legislature when they have questions that relate to healthcare policy. Finally, we have Carl Steady. He works with Mid-State Health Care Center and serves as a healthcare navigator for the new healthcare marketplace. Performs that functions both for individuals as well as small businesses, and has a raft of experience doing just that in other locations. With that as an introduction, please join me in welcoming our three panelists. Michelle, please.
Thank you. I'll try to speak loudly, but if you can't hear me in the back, please raise your hand. I called my talk today, the Affordable Care Act, perspective of a small community hospital. And that's because our perspective will be slightly different than a larger hospital system. I think the challenges may be similar, but some of the opportunities will be different because of the size of the organization and the fact that we're in a small rural community. I have to coordinate giving him a message. So I'm going to start with a very simple overview of the Accountable Care Organization, or should I say the Accountable Care Act. Hopefully it's not too simplified, but from our perspective, there's really just two major important components to the Accountable Care Act. One is it tried to increase coverage for individuals. As you know, there's millions and millions of individuals that are uninsured, either throughout the year or even for periods of the year. And so the intent was, how do we increase coverage? Because if we can get individuals with access to insurance, then they can have better access to health care services. And the hope was to develop a system where there was shared responsibility for this coverage. It was not about creating a single payer system. It was about how do we build on the system we currently have and increase access. The second major component of the Affordable Care Act was payment reform. Ever since the beginning of Medicare and Medicaid back in 1965, they've really built on a system of paying each time as a service rendered. And that was really paying for volume. And they're saying we should be paying for value. We should be paying for the outcome that we want to achieve. value, as you all know, is an equation that results from lower cost and higher quality. And so those are two components of what will be included in payment reform. Talk a little bit about increased access. As I said, coverage will increase access to care, but it'll give access to care at the right place and at the right time. A lot of people say, well, everybody has access. They can go to the emergency room. And they're right. They can go to the emergency room and they will get care. But it's not the right care. It's not the right place. There is a role for emergency rooms, but it's not for managing chronic illnesses. It's not for getting prevention and wellness. It's for really those acute episodes of illness. So the hope is that if we can get people access to the right care at the right place, we will reduce ER visits, and we will have them develop a relationship with a primary care provider who can diagnose and treat their chronic conditions, as well as give them access to prevention and wellness. If we can better manage people's health, we're going to reduce overall healthcare costs in this country. On the coverage side, I talked about shared responsibility. And this was done really, I'll call it 3 mandates. One was the employer mandate. There is a component in ACA where it requires large employers, and that's defined as 50 or more full-time employees, although the federal government's used a different definition of what a full-time employee is than what we use in traditional business. But if you don't provide coverage, there will be a penalty that you will pay. There's also an individual mandate. And that's the responsibility that each individual pursue coverage. If they don't, there'll be a penalty. And I forgot to mention, large employers will also have a penalty if they don't provide coverage to their employees. The third mandate was really a state and federal mandate. And there were 2 components of that. One was that each state was going to expand Medicaid. As you all know, that did get overturned by the Supreme Court. And now each state has to make that decision. And New Hampshire is still trying to make that decision. We just got the report from the Legislative Commission looking at this yesterday, but as Lou said, we still have to go through a special session to really say, are we going to do this or not? The second piece was developing health insurance marketplaces. Again, states had an option. They could do their own, or the federal government can do it, or there could be a partnership. Again, New Hampshire decided early on that they did not want to do their own. They were going to let the federal government do it, and then when Governor Hassan came into office, she did decide we would do the partnership model, which is a state-federal partnership.
No.
No,
The slide over there.
the slides were just out of order.
Oh, sorry.
Go back one
We're
slide.
okay.
Thank you.
Go back one slide, page 4.
But we're up to date now.
Okay,
Page 4.
Yeah.
That's it.
All right. Talk about the payment reform piece of it. As I said,
Next one, Bob. I'm sorry.
we've been on this piece of service.
3 and 4 were reversed.
Go to page 5.
Okay, that's
There we go.
5.
Thank you.
Michelle, this is a friendly crowd, but
Yes.
you don't have to explain it as you guys stand for.
My apologies, I can't see where you are, so I'm just assuming we're in sync. We'll talk about the payment reform piece. And as I mentioned, since 1965, Medicare and Medicaid have paid us on a fee-for-service basis. But we see really 2 waves coming, 2 different phases of changing how healthcare providers will be reimbursed. This first phase we're calling a transition to value-based purchasing. And that's the federal government saying, there's certain things that we want to incent for, and there's certain things that we're not going to pay for anymore. And one of those is no payment for adverse events. There's some people in healthcare here, so they know sort of some of the idiosyncrasies in healthcare, but some of you may not know that in the past, if a hospital did an error, for example, if we left a sponge in an individual and had to bring them back to surgery to remove it, or if they fell out of a bed and broke their hip and had to stay longer, we used to get paid more for that. If we brought our car in to get fixed and they broke something, we wouldn't pay more for that initial repair. In fact, we probably wouldn't even pay for the initial repair. But that was one of the things that they wanted to change in healthcare, to say, we're not going to pay for adverse events. If a hospital does an error, they own it. The second piece which is coming is a reduction in payments for hospital-acquired conditions. Some examples of hospital-acquired conditions is that if you're in the intensive care unit and you've been put on a ventilator, you have a high probability you might get pneumonia if we don't do the right things, called bundles. So if you get a pneumonia while you're on a ventilator or a hospital, that's a hospital-acquired condition. If we give you a Foley catheter, you get a urinary tract infection from that catheter, that's a hospital-acquired condition. Again, it's saying we want quality out of services, and we're not going to pay for these types of things. And the third piece is incentives, and I'll define incentive from a government perspective, but incentive payments for meeting targets for compliance with evidence-based practices and meeting targets with patient perception of care. Now, the way the federal government is going to incent us is they're going to take money away from us, 1 to 2%, and then we have to earn it back through meeting these targets. So that's their definition of incentive. The evidence-based practices are things that they've been having hospitals supply them for a number of years. They focus on 3 different diagnoses, which are the major diagnoses that Medicare patients usually see in a hospital: community-acquired pneumonia, congestive heart failure, heart attacks. And then the fourth one is called SCIP, which is the Surgical Care Improvement Project. This is standards that you should be implementing for surgical patients that are reducing the risk of error and reducing the risk of infection. That's affecting large hospitals already. It will affect small hospitals. They're saying potentially by 2015. Six. Great. The second change to payment reform will be getting to their ultimate destination, which is really getting to population health. They don't want to pay for injury and illnesses. They want to be able to transition to paying for keeping people healthy. How do you keep community at optimal health? That takes a dramatic change from how healthcare is delivered today. And they understand it's a big change. So the ACA had a number of opportunities to sort of practice and define what can deliver that best outcome as far as population health management. So there's 2 major areas that they're doing pilots and demonstration projects on. One are ACOs, those are called accountable care organizations. And that's where an entity or a group of entities can come together as one legal entity and really manage the health of a population. To say, okay, we think we can, historically, if it costs you $200 a month to manage the health care of a patient, can you do better? And they'll monitor that. And if you do better, you get to share in some of that savings. In some of these groups, there's actually risk. If you do worse than 200, there's financial risk that as parties are involved. So there's a couple of different ones. Some risk associated, and some that are only on the upside. You get a positive benefit if you've been able to manage the population's health or your population's health within a target budget. The second is bundled payments. This one is a lot less known, but they're looking at saying, right now, if there's an illness, and let's use a hip fracture, for example, or hip replacement, you may start with your PCP because you've got pain in your hip, who may refer you to the orthopedic surgeon, who upon evaluation will say, well, let's get some x-rays. Based on the x-rays, they'll say, we think we need a joint replacement, so we bring you to surgery. You've got a hospital stay. You may or may not go to a rehab hospital after that. And then you get discharged home and have outpatient physical therapy. That's about 7 different providers. They all used to get a separate check, a separate payment. Under a bundled payment, there'd be 1 check. And 7 individuals will have to figure out what piece of that check they would get. And I can assure you what it drives is having all those 7 parties work together to say, okay, how can we work together to make sure we're taking care of this patient in the best manner possible, in the most efficient and effective way possible. ACOs do the same thing. It's really an incentive to say, how do we coordinate care better to make sure that patients can manage their health? So it's really driving care coordination and really focus on keeping people healthy and how to be more efficient and effective in care delivery. So that's the end of my very high overview of ACA. Now I'd like to talk about the hospital's role in ACA. From a general hospital perspective, because next we'll talk about SPEAR specifically.
I have a question.
Can we hold the questions to the end to allow all the speakers to come to the front, because they may well be answered in the flow.
I'll try to remember my question.
Give you benefits. Thank you.
We all share the role in trying to increase access. If individuals got access to insurance, they should be able to access healthcare providers. So hospitals and private clinics and home health agencies, we all want to be part of that solution. What we're seeing is to be part of the marketplace, most of the insurance companies that are participating in this are trying to offer a product that is a lower premium than the commercial market. To do that, there's two major components. We're seeing narrow networks. We see it in New Hampshire, and we see it in many other states where it's only a few providers or half the providers in the state. They're also going to be paying providers at a lower rate to be able to keep the premiums down. We all play a role in assisting our community in navigating the different coverage options. I probably shouldn't use the word navigate because you're a navigator, but helping our community really know what the options are and helping them be able to access that information, be educated, and assist them in whatever we can, in whatever way we can, so that they can make their decision. The third part certainly affects hospitals, but probably is not that well known in the general public. But somehow they had to pay for healthcare reform. Penalties were one part of it. There's taxes on medical devices and other components to it. But one of the components was also a reduction in hospital reimbursement over 10 years. It was already prescribed in ACA how much they would be reducing the reimbursement for the large hospitals. For the small hospitals and other providers, they created something called the IPAD, Independent Payment Advisory Board, and their task was solely to look at how do we get more savings out of Medicare. So critical access hospitals such as Spear would have fallen under that board to decide what's the future for our reimbursement. Additional roles for the hospital is increasing our value proposition. As I said, we're moving towards value being built is the premise for payment. Quality and patient safety play a big role in that. And I've talked about things like adverse event, preventable harm, but also increasing our efficiency and our effectiveness. We also play a very important role in assisting and improving the health of our community. I talked about care coordination. It's not just one type of provider. It's all providers working together for care coordination through sharing of important healthcare information. We've all been independent agencies. We've all gotten our separate payments. We also all have our separate medical records. And we may not have the total picture of the patient, so information technology and sharing is a very important component of ACA. And it's also our role to participate and assist in demo and pilot programs. And I say assist because that's probably what small hospitals are going to do. When you have large healthcare systems or large hospitals like Dartmouth, they have enough critical mass, enough volume to really be their own ACO. And that really doesn't pertain to small hospitals. But we see that we can have an important role helping others that are ACOs. So now I'd like to talk a little bit about what Spear's done, is doing, will be doing in regards to ACA. First of all, we have successfully concluded negotiations with the New Hampshire Managed Medicaid organizations. As you know, New Hampshire made the decision to move their Medicaid population into managed care. If New Hampshire expands Medicaid, there may be an important role for these managed care organizations to be in there. So it's very important that all of us are participating in managed care organizations. We've also successfully negotiated with Anthem, which, as you know, is the only insurance company in New Hampshire that's participating in the health insurance marketplace. They are providing a narrow network, and we are one of those hospitals that's in that network. We've been addressing how do we become more efficient and more effective. Over the past year and a half, we spent a lot of time educating our management and our staff on things that really came out of the manufacturing industry, lean technology. How do you do these little systems in a more efficient manner so that you're reducing redundancies, you're reducing waste, you're reducing audit times because you haven't hardwired the systems initially. And how do you just get things more streamlined so that you can provide the same service, same level of quality or higher, but do it with less resources. In fact, just this past year, we set a goal for our organization to say, you've all been trained, look at your internal operations, identify opportunities. And through their efforts, we were able to put $250,000 on our bottom line through implementing lean and process improvement. We've also focused heavily on quality and patient safety. Federal government required all large hospitals to start reporting on these evidence-based practices that I talked about earlier. All of New Hampshire's small hospitals volunteered to do so as well. We don't see it as just a payment issue, but if you follow evidence-based medicine, if you follow these protocols, you're going to have a better outcome for the patient, or it's more likely that you'll have a better outcome for the patient. We've decided we want to participate because that's the quality of care that our communities deserve. So SPEAR's been reporting for a number of years. This is available on the federal government's website, Hospital Compare. Two of our scores I've highlighted here, CAP, which is community-associated pneumonia. These are composite scores. So for pneumonia, there may be 6 different measures that they're saying you should be doing these 6 different things. Did you do all 6 of them each time it was needed to be done? We have a composite score of 97 as compared to a national score of 95 and a New Hampshire score of 93. The same thing with our surgical care improvement project. We've got a composite score of 94, again slightly higher than the national average and New Hampshire average. Government has now worked into the outpatient side, saying now we're going to look at outpatient because a lot of medicine used to be predominantly inpatient. A lot is done on the outpatient side now because of advancement in medical technology. Many hospitals, small hospitals, are not participating. We have chosen we're going to participate. We want to know where we have opportunities to improve care for our community. I'll give you just one example. For heart attacks, they're measuring the time it takes from the time a patient walks in our door in our emergency room to the time they get an EKG, which is one of the deciding factors is what's going on with this patient. Is this a heart attack? When we first started collecting this data, it took about 14 minutes from the time the patient came up through our doorway to the time to get to an EKG. We've got that cut in half to about 7.5 minutes right now. Pretty quick. Some large hospitals struggle to get this kind of quick time frame for response time to patients coming through the door. We're also committed to improving patient safety. I'm always fearful of talking about patient harm because certainly we don't mean to harm patients. It is just something that happens in our industry, and I've given you some examples of what patient harm are. But we're focused on them, and we're saying, what are they, and how can we prevent them? Each time they happen, we do root cause analysis. How can we have prevented it? How can we change our processes and systems? In this past year, we were able to reduce preventable harm by 22%. Our biggest opportunity is patient falls with harm. And this has really become a difficult one for us because we realize now what it's come down to is patient privacy and patient safety. We've been able to trend most of these falls are happening when patients are trying to go to the bathroom on their own without nursing assistance. They want that privacy. They don't want to be assisted, but yet that's where the falls are happening. That's our biggest challenge now we're facing. We're doing additional patient education, family education about safety of the patients. We're also making revisions to our bathrooms to try to make them safer, to having railings on just one side, there'll be railings on both sides, so that patients have an ability to get up, hopefully the opportunity of reducing patient fall. SPEAR chose early on, if there was an adverse event in our hospital, we were going to own it, and we were not going to build a patient, we were not going to build an insurance company for this. We did this several years ago. Now it's mandated by the federal government, but we chose early on to say we have to acknowledge when we do an error, and it isn't right to build more if there's something that we have to fix. We're just starting to work with the North Country ACO. I know Fred Kelsey's in the audience. He probably didn't want to be recognized, but he is the medical director for Mid-State Health Center, but he's also the medical director for the North Country ACO. And he's been able to, hopefully we've been able to supply him with the data he's requested so far. He's been studying ER utilization to say, how can we, why are people using the ER and what opportunities do we have to reduce that? There's going to be more and more of that information asked for, and we really see that it's important to share that information, to be very transparent, and to work together to say, okay, how can we accomplish these initiatives that we want to accomplish? The next piece is really about readmissions. Another focus of the federal government is say, if patients are discharged from a hospital and they need to be readmitted in 30 days, within 30 days, there's something wrong. We haven't educated them, we haven't given them the right support system, we need to do a better job. So this is really a large initiative through the Central New Hampshire Health Partnership. We were able to get a federal grant from HRSA. SPEAR's piece of it, one component of it, is a nurse that we have on staff that works with each patient that's declared to be high risk for readmission in reaching out to them with phone calls, home visits, teaching, being a patient navigator, getting them back to follow-up appointments, following their symptoms to say this is something we need to pay attention to. We've been able to reduce our 30-day readmissions from 9% to 6% this past year. I've been getting them, so I'm going to hurry here. I talked about information sharing. We've done a lot of investment in our information technology, building interfaces, because we've all got different electronic records that don't speak to each other. That will be continuing. We'll be doing that for years, building these interfaces. We're also getting some of our staff as certified application counselors, so they can also help in getting our public aware of what the options are and connected to what the options are for increased coverage. We'll go to There's a lot of good things in ACA. It doesn't resolve all the problems. It does present some challenges and some concerns for us. At a very high level, I'll go through these very quickly. As I talked about, there's an individual mandate and there's penalties. The penalties are very, very low. So we're not quite sure if people will make that decision to pay that premium, particularly if they can't get a subsidy, or pay a penalty. First year penalty is $95 or 1% of your income. It increases, but it never increases substantially to equate to what a premium would have to be. We have concern about the matching of what the small employers will be doing in the community. Many of them have done a great job trying to provide coverage to their employees. Not all small employers do that. Is this going to be an opportunity for them to stop providing coverage, perhaps give their employees additional income, and send them out to the marketplace? And we're concerned about that because, as I said before, there's low reimbursement. If these people are covered by a commercial insurance company today and join the marketplace tomorrow, it's the same individual we're serving, but we're getting paid a lot less to provide their service. In fact, we paid less than it costs us to provide that service. We all are concerned about the impact of New Hampshire's decision to expand Medicaid. And somewhat related to that is decreased DSH funding. DSH is disproportionate share of hospital funding. That is funding that the federal government gives to the state, that the state then shares with hospitals that provide a high level of uncompensated care. Those being they have a high percentage of Medicaid in uninsured individuals. The premise of ACA is that there will be a lot less uninsured individuals. So therefore, there doesn't need to be as much federal funding to the states. New Hampshire uses a lot of this funding, coupled with a Medicaid enhancement tax, to help fund the general fund, as well as to provide some DSH payments. And if they're going down and New Hampshire does not decrease its uninsured, it really doesn't make the situation any better for our state. And then everybody, hospitals, large and small, are going to struggle with, can we achieve the cost savings that are necessary to provide the same service, the same quality, with what could potentially be for a lot less reimbursement. Thank you.
I think I'm going to stand because my voice doesn't carry very well. So even then, if people at the back can't hear me, just wave your hand or something and I'll get the idea. The other thing I'm going to do is I'm going to hand out a copy of my presentation. Only got 25, so if you don't get one, then we'll make additional copies and we'll be able to get you one. Take one passed around. I love talking about insurance late at night. I'd like to start there. Well, that's being set up with a question for you. Who knows what the insurance department does? Why do we even have a state insurance department?
I know it makes sure that the insurance companies do what they say they're going to do, because otherwise we're on the horn to you.
Right. Make sure insurance companies do what they're supposed to. Because insurance is regulated at the state level, and at some level, if you want to get a claim processed, a claim paid for, well, who's your outlet if you don't get a claim paid for? You go to the insurance department and say, my insurance company isn't paying my claims, or anything you can do. Or they did something that just doesn't seem right. Well, insurance is regulated at the state level by the New Hampshire Insurance Department. We don't regulate healthcare providers, and when I talk about insurance, I'm talking about commercial insurance. So I'm now talking about Medicare, the program for people who are over 65 or disabled, and I'm not talking about Medicaid, essentially for low-income people, as long as they're eligible for another reason as well. such as they're pregnant or they're a child or they're disabled. So within the other markets, the insurance, the commercial insurance market is where the insurance department has regulatory authority. To the extent Medicaid is moving into a commercial area where they've got managed care organizations that are providing care, there starts to become some overlap between what the insurance department does and what DHHS does. We license these companies, but beyond that, they have to fulfill the requirements, the DHHS and the Medicaid requirements that exist. Still open?
Loading will be there in a second.
Okay. So you've got this ACA, this federal law, but insurance is regulated at the state level. So how is that going to work? Well, we spend some of our days trying to figure that out. The short answer is that the good thing about New Hampshire is we have a lot of laws on the books, state laws, that accurately reflect what the ACA already had in place. So things like for small employer coverage, and I'm talking about different insurance markets, but for small employers, they weren't allowed, insurance companies weren't allowed to underwrite the premium based on how healthy or how sick those populations were. That's a part of the ACA too, except the ACA extends it to the individual market, where historically in New Hampshire, it's been essentially medically underwritten. And if you're really sick, you couldn't buy an individual policy. Insurance companies wouldn't sell it to you. So you had to go into the high-risk pool where you could buy insurance, but it would be more expensive than what you would have paid in the individual market. So the individual market has benefited people who were healthy, in many cases young, and were okay with higher deductibles. That's generally been your individual market in the past in New Hampshire. So if you get to the second slide. So when I talk about the insurance markets, they're all regulated really differently. And I realize this is a lot of stuff late at night, but before I talk about what's going to change, I got to talk a little bit about the way it is right now. And can you hit you? Yep. Maybe. Okay, good. We're there. All right. So the first thing to know is that most people actually don't have true insurance. So I have an Anthem card. I work for the state of New Hampshire. It looks like anybody else's with commercial insurance. The thing is, the state of New Hampshire is self-funded. That means what they're paying Anthem to do is they're not buying insurance from Anthem. What they're actually getting is management of benefits and the claims processing, and some of the other things like network development and some of the other traditional insurance functions. But if I, on the way home, get run over by a bus and I end up with $1 million in claims expenses at Spear Memorial Hospital, all that goes back to the state. The state might buy reinsurance, but they're not buying health insurance in the traditional fashion. And that's true about a lot of large employers. In fact, more than half of the people walking around with cards like mine are in these larger employers that are self-funded. So what does that mean at the end of the day? Well, the short answer is they're not subject to the insurance laws we have in the state. So if the legislature passes a mandate requiring insurance companies to cover hearing aids, that doesn't apply to those of us under these self-funded larger employer accounts. It makes managing or regulating insurance somewhat challenging. At some level, these companies are managed by the Department of Labor, but that's a different set of rules. Why do large companies self-fund or self-insure? Well, the first reason is that if you've got enough people in your pool, you know what the costs are going to be on a year-to-year basis pretty well. I mean, it's just stable. And if you've got a large enough population, you've got a critical mass, it becomes predictable. Some of the other reasons is that if you're implementing programs to improve the health of your employees, their population-based health, you want to reap the benefits of that. So if they end up costing less next year, you want to make sure that comes back to you as an employer in your account. You don't want that accruing to an insurance company that's, well, potentially seeking profits. One of the other reasons these large employers tend to self-fund is they tend to be large enough to cross state borders. So they're operating in a lot of states. And they don't want to be subject to different state regulations in different states. They can self-fund and they can avoid some of those requirements. A lot of the ACA requirements don't apply to large employers or these self-funded accounts. Some of them do, like no lifetime limits and preventive care things, but a lot of it does not. So when we break down our insurance market in New Hampshire, which is at least 600,000 people, about 55% are under these self-funded employers. About 76% of people are covered by large employers in total. So of those, about 29% is regulated as insurance, is truly insured people. So 140,000 out of those, that large employer market. And again, most people fall under that So when we talk about a lot of the changes related to the ACA, particularly the exchange, the marketplace, whatever you want to call it, we're not talking about large employers. We're not talking about self-funded employers. We're talking about small employers in the individual market. And today in New Hampshire, about 24% of people are in small employers or the individual market. So I'm telling you this to try and keep everything in perspective. So all this you hear about the exchanges and the marketplace and having to sign up and Anthem's narrow network, it doesn't apply to most people, even in the commercial insurance market. It definitely doesn't apply to you if you're Medicare or Medicaid. So keep everything in perspective. So today we've got 110,000 small employer, about 40,000 individual members. Those numbers will swell in 2014. But they still won't become 600,000. I mean, when you think about that, that's 110,000, 40,000 individual. Even if the individual market goes to 70 or 80,000, we're talking about that in the context of 1.3 million people in the state. So really pretty small at the end of the day. Next slide. The other thing to know about insurance, commercial insurance, is it's dominated by just a few different companies. And you can see from this chart, Anthem is huge. Anthem dominates the market by a long shot. In fact, this understates Anthem's dominance because it doesn't include the federal employees that are covered by Anthem, as well as some folks that are covered through national accounts but sort of managed by the local Anthem plan. That would add about 40,000 people to that, bringing them up closer or over 300,000. And you can see Cigna and Harvard Pilgrim are also big players in New Hampshire, probably not a surprise. The other takeaway from this chart is you can see how many of those people covered by those insurance companies are either self-funded employers or fully insured. And you can see that Anthem is about half and half, Harvard's about half and half, a little more on the fully insured side. Cigna is much larger on that self-funded side. Their business strategy is to develop products for self-funded employers. You go down from there, it's much smaller. Aetna, if you're covered by Aetna in New Hampshire, chances are you're under a large employer and you're self-funded and you're outside the regulatory system. MVP, they've been fully insured, and if you haven't heard, they're exiting our market. So we've only got a few different carriers. We've got a bunch of small ones, have a few people, but in general, we have a very concentrated market in New Hampshire. The thing is, that's not unusual. Across the country, in 99% of markets, it looks like this. Not necessarily these companies, but just a few of them. Why is that the case? I'll get to that in a second. Next slide. When we talk about competition in insurance markets, there's sort of this theory that if you could buy insurance across state lines, it would be really cheap. Well, when we look at the way insurance companies compete with each other, they compete on a few different areas, but the main factors are their medical claims costs and their insured population health status. What do I mean by medical claims costs? It has a lot to do with the provider contracts. So they don't pay the provider charges. They don't pay the charges at Spear Memorial Hospital or any other hospital. They go in there and they negotiate. They say, well, we'd like to pay you 80% of charges, or we'd like to pay you using a different system that equates to 80% of your charges or something less. And they're more successful if they can go into a hospital, if they're an Anthem, and say, I've got 50% of your commercial members. And if you don't negotiate with me, if you don't give me a good deal, I'm going to make your life really difficult. I'm going to try and send my members someplace else, or I'm going to try and move them out of the hospital. I'm going to do whatever I can to get the best rate with your organization. Well, you saw one of those companies up there was Usable Insurance. How effective is Usable going to be if they go into Spear Memorial Hospital? They probably wouldn't even get a meeting with the CFO. Well, Michelle's pretty nice. She probably would meet with them. But a lot of hospital CFOs wouldn't. I mean, why do it? I mean, they've got 3 members in your community. They may end up in the hospital. And if the company tries to steer them someplace else, like from Concord to Manchester, I don't know, they may lose a member. It's really not in their interest to spend a lot of time negotiating with these insurance companies, but it is in their interest to negotiate with an Anthem or Harvard Pilgrim or Cigna. So that means your largest insurers get the best deals, and it becomes very difficult for a small insurer to offer a premium that is competitive with any of these large insurers. And if you look at the percent of the dollar that we pay in health insurance premiums, almost all of it goes out in terms of insurance claims. On average, it's about 85 to 90%. So if you look at relatively small differences in the amounts paid to healthcare providers, it means big differences to the health insurance company. So like if you think of the delivery system, the marginal cost of seeing another patient is relatively small most of the time because hospitals are largely fixed costs. On the insurance side, the marginal cost of insuring one more person is really high. So the deals you can get to control those raw material costs are really important. There are some other factors. One of the other main ones is the population health status. Some of those small insurance companies have been able to continue to exist in New Hampshire because they insure healthy people. I mean, that's the bottom line. If they can't sell premiums based on their contract rates with providers that are competitive with Anthem, well, they can do better by just getting the healthy people who don't have insurance claims. It's been a good strategy. The ACA is going to change that. It's going to actually reduce the advantage with insuring healthy people in those individual and small group markets. There are other factors that insurance companies compete with each other on. Membership to a degree, underrating whether they're self-funded, whether or not you can spread your administrative costs, organizational efficiency. It is an industry that favors size. Surprise, right? Anthem can take advantage of economies of scale that even Harvard Pilgrim can't. And Harvard will admit that. They've got to offer something unique. Even though they're large in New England, they're nothing like Anthem National. There are return on investments. Insurance companies do something with your money before they spend it on claims. And then there's, well, customer service, but never as much as we would like to see. So there are some areas where they compete, but the main areas have been medical claims costs and the insured population health status, and closely related to those provided contracts. So we talk a bit about kind of the networks in this contracting and these good deals or bad deals that they do or don't get. And there certainly has been a lot of attention around Anthem's narrow network. Because historically, insurance has included most of, if not all of the hospitals in the state, almost all of the time. In fact, most of the doctors have almost always been in the network. But this is a bit of a new approach. A number of years ago, 15, 16 years ago, New Hampshire passed a law that said an insurance company must have an adequate network in the state. Adequate was a floor, a very basic network, sort of the worst case scenario. And it basically had to do with how far you had to travel for hospital services or certain specialty care services. And basically it said 45 minutes to an hour. If you can get there within that amount of time, then the network's probably adequate. Those rules, we have a law and then we have rules, and both are referenced there. The rules are the real specifics of what would otherwise be in the law. They are in need of updating. And it's kind of interesting because in the spring I kept telling people, I'm going to update the network adequacy rules this summer. It's one of the things I need to do. It's on the agenda. And then, of course, it became hugely relevant this fall, so I can't decide if I'm unhappy I didn't update them or happy that I let somebody else sort of deal with the issues around it. Nevertheless, we need to recognize the healthcare system is changing. It's evolving, unrelated to the ACA. So we've got a number of things going on. We've got an investment in community health centers, a great place to get primary care. We've got increased use of what we call mid-level providers, nurse practitioners, physician assistants, health coaches, community health workers. You don't always need to see a doctor for everything that you have a problem with. We use telemedicine. You don't need to travel all the time, particularly if you can get access to telemedicine services. We've got hospitalists that are filling in for patients who are treating patients in a hospital setting when otherwise the primary care provider would have had to go into the hospital to see those patients. That's going to free up the primary care provider a bit more. We've got urgent care centers and other walk-in clinics. You may see an emergency medicine physician in there. You may see a family practitioner. You may see a midwife. The point is you've got increased capacity within the system treating patients in different settings. And this is a natural progression. We've got accountable care organizations. Michelle talked quite a bit about that, trying to make more efficient use of our resources. We've got many hospital services being provided in non-traditional settings. In fact, down the road, you begin to wonder what services in a hospital couldn't be done in another setting, perhaps more efficiently. So the way we think about a hospital, I think, is going to continue to evolve and change. Even when we think about good quality health care, it's often done in places where people have a lot of experience with it. I mean, you're not going to get a lung transplant at Concord Hospital. You're going to go to Boston or something like that because they do more of it. Even to the extent we talk about cardiac surgery, is that something that's appropriate at Concord Hospital? You probably don't want it in the North Country, but maybe going someplace like CMC is really a good place to go. So when we think about where we get health care in the most efficient location, we're thinking about quality and we're thinking about cost. And it's not necessarily the high-cost places where the good quality is. In fact, a lot of the evidence suggests the other way. So the point is the network adequacy rules do need updating. We've got a lot of changes going on. And to the extent that we're talking about the ACA, most of it actually doesn't have to do with most of the ACA provisions are not impacting what we're doing with network adequacy and what Anthem's doing with their network. Next slide. So Anthem's pathway network doesn't include all the hospitals in the state. I did comply with the network adequacy requirements. In fact, they openly admit, they said they started with the network adequacy requirements and built the network up from that. Remember I said this is sort of the floor, sort of the worst case scenario of a network. Really put it in place so an insurance company couldn't come to the state and tell you, well, we're going to sell you cheap insurance, but you got to go to New Jersey to see your doctor. But it's, you know, it's still is what most people would like to see. So according to Anthem, they indicate their premium savings about 25%. It will impact members at varying times in 2014, primarily in that individual market and to an extent the small employer market. The small employers who buy their Anthem insurance coverage through the exchange. The primary issue is that 10 of the 26 hospitals are not included, and Anthem is the only carrier on the exchange or the marketplace. Why did that happen? Well, because they're the only ones who decided to sell on the exchange or the marketplace. And all of their national research said if we're on the exchange or the marketplace, price is going to be hugely important to the consumer, more important than anything else. So if we don't have the lowest cost insurance, they're going to go to somebody else. I mean, that was the whole theory. If you look across the country, Anthem is definitely not unique in terms of their narrow networks. And Michelle's out there. She's absolutely right. Will we see another carrier in 2015? So only a year with only Anthem as a selection? Yeah, probably. Whether or not it'll be in the individual market, I hope so. Harvard Pilgrim has expressed an interest in being on the exchange or the marketplace. They haven't gone so far as to say whether or not they'll be in the individual market. They may just be in the small market for all we know. There are individual insurance carriers that you can buy insurance from outside of the exchange or the marketplace, but you probably will pay more for their insurance, in part because, well, they'll have a broader network, and also you won't get access to the subsidies going through the exchange, which is the big carrot for buying your insurance on the marketplace or the exchange. So, as you have heard, there has been a lot of controversy about Anthem's network. Will there be a legislative solution? And I use that term better loosely. I think there'll be legislation brought in. The problem is that if you pass legislation that requires the insurance companies to contract with hospitals, with particular hospitals, so for example, at least one hospital in every county, you're passing legislation that gives the hospital an immense amount of leverage in that negotiation. I mean, if the insurance company has to contract with the hospital, why would the hospital provide a discount? I mean, maybe they could do other things to make life more difficult for that hospital, but geez, I mean, you're changing the dynamics. So then it raises the question, well, should the state be involved in how much they pay the hospital? And this is that interesting dynamic where we're always struggling with how much the government should be involved in something. And currently our network adequacy rules, they make reference to sort of competitive rates. But what exactly are competitive rates? And I mean, would you compare it to all the other hospitals? Would you come up with an average? Would you come up with something that's more nationally based? I mean, the insurance department has the ability to do some of that, but a lot of people don't feel as though that's the role for a government agency. And that's the big question. Next slide. So changes to 2014, now that you're all experts on insurance and markets. Some of the things you've heard about, and I'm going to go through this much faster than I'd like to, but you've got your handouts. I've included a lot of references in the last couple of them for additional information. You've heard about the individual mandate. Yes, the penalties are quite low. We expect, even in 2016, a lot of people who are currently uninsured will still be uninsured, unfortunately. There are new rules for that individual and small group market. The individual market will be a lot like the small group market. So that means they can't charge your premiums based on how sick you are. That means they can only adjust your premiums based on age within certain limits and whether or not you smoke, essentially. Moving from using industry size, the actual group size of the employer, and a couple other things in certain circumstances. There are essential benefits that have to be covered under insurance in these markets in 2014. There are 10 broad categories, and for the most part, they cover the types of categories you expect insurance to cover. Emergency services, hospitalization, maternity, newborn care. They do cover a couple of things that you might not expect, such as pediatric dental services and vision care, but nevertheless, for the most part, there are 10 broad categories. There is what we refer to as guaranteed issue in the insurance sort of lingo. What that means is they have to offer you insurance. They can't tell you they're not going to sell you insurance for whatever reason. And historically, that's a change for the individual market, where again, you've got cancer, we don't want to offer you insurance, we know it's a bad deal for us. Interestingly enough, in the individual market, it didn't even include maternity benefits. You had to buy that as a rider. Well, who bought maternity benefits as a rider? People who plan to use them. So what do you think the cost of the rider was? Well, about the same cost as you pay for maternity benefits on your own. So it's kind of interesting the way insurance works. But that'll change in 2014. Some of the new rating factors: past, age, health status, group size, industry tobacco. Future, age, tobacco, geographic rating is a permissible factor. New Hampshire is going to have one geographic area, so that's our geographic rating. It'll be the same across the state. There are reference to metal levels, so bronze, gold, or silver, or platinum. Basically what that means is how much cost share you have, how much in your deductible, your co-insurance, or other potentially co-pays. And if you've got a richer metal, you've got lower cost share. If you've got a weaker metal, bronze, you've got higher cost share. There are requirements for large employers. They were bumped out to 2015. Historically, if you look at healthcare policy debates and such, there was always the one debate was saying the employer should be on the hook and required to make sure they provide coverage. The other was, no, the individual needed to have some individual responsibility. Ironically, that was the Republican approach, and the Democrats were favoring the employers. But nevertheless, we ended up with some bit of a combination. Next slide. So the marketplace, or the exchange, and the shop exchange. The shop is essentially that exchange marketplace for small employers, not large employers. They're not allowed to buy insurance there yet. So individual small employers only, I can't emphasize that enough, not Medicare. What New Hampshire has is we refer to a federal-state partnership. All the states had the option to build their own exchange or marketplace, do it the way they wanted. Yes, they had to follow the federal rules. New Hampshire decided, a lot of people in New Hampshire, some people in New Hampshire decided that we should not do a state-based exchange, and they passed a law to make sure we wouldn't do it. In fact, the insurance department was accused that we were planning to do it over the summertime. So, we didn't try. It does include Medicaid. So to the extent you would go to the exchange and see if you're eligible for Medicaid, potentially be able to enroll, that is something that was set up. The idea was no wrong front door. There are subsidies for individuals, and they are up to 400% FPL, which is a lot. For a family of 4, that's like $90,000, and for a family of 1, it's around $45,000. There are tax credits for small employers, and it was supposed to have gone online on October 1st and away. I guess it did. There are a lot of problems, apparently. And that's for coverage beginning January 1st, 2014. After that, there will be open enrollment periods that start October 15th and end December 7th. We have open enrollment periods so that people don't wait until they're sick to sign up for insurance. That type of model doesn't work very well. The bad news is if you miss the open enrollment period, you have to wait until the next one. There are such things as qualifying events that allow you to add people to your insurance policy, such as if you lose your job, get married, have a baby, those types of things. It's the same as it is in today's world. And you can still buy insurance outside the marketplace. It's just that carrot to get either the tax subsidy or the individual subsidy. Almost there. So the subsidy availability, 1 to 400% FPL. Those are the numbers that it looks like. Those under 100% FPL are not eligible for subsidies. That's because the ACA assumed the states would expand Medicaid for that population. If we don't expand Medicaid, those people are a bit left out on their own. That would be unfortunate. I won't say anything more than that. Next slide. That's what the subsidy sort of scale looks like, and it's real time. So if you're buying your insurance, it's not. You don't have to wait till the end of the year when you do your taxes, and you can calculate the monthly premium contribution based on the percentage of your income, because that's how it's done. You don't actually even need to know how much the premiums they are themselves, because it's a factor of your income. And you can't pay more than 9, or you should be paying more than 9.5%. That's where it tops out. And that's the scale. And there are online calculators, and of course, if you're able to use the actual exchange website, then you should be able to just go through this and get access to those subsidies. There are also cost-sharing subsidies for folks in the lowest incomes, so below 250, to help with them pay. The individual mandate, I've covered much of this already. It's 2014. Everybody must have insurance. Your employer coverage, Medicaid, Medicare, they all qualify you as having coverage. There are limited exemptions to penalty. If you don't file taxes, you're not required to do it. And there's some religious exemptions too. It's administered by the IRS, not the New Hampshire Insurance Department or anybody else at a state level. Those are the penalty amounts. They go up each year. 95 or 1% of your income. So if you make $1 million, it actually is expensive. But if you have $1 million, you're probably not worried about the cost of health insurance. It does go up to about $700 in 2016. There is assistance in the state, and there are folks that are trying to get people signed up, despite a lot of resistance in New Hampshire for making this happen. Obviously, the federal website and the toll-free call center, there are navigators, by-state primary care, community health centers, and New England Planned Parenthood are our navigators. Those are federally funded folks through a grant system to help people get access or get knowledge about the exchange and sign up for insurance. They're not brokers. They're supposed to help people get familiar with a lot of what we've already talked about. Certified application counselors, think about those people who work in hospitals. They used to try and get people signed up for Medicaid if they came in. They use the same type of thing, get them educated about the commercial insurance. Small Business Administration, New Hampshire Health Plan, they used to administer the high-risk pool, still do for a little bit longer. They're in a position now where they got a $5 million grant to do outreach, and they're getting that pretty quickly. Agents and brokers, insurance experts. Health insurance companies will help, IRS to a degree, and then Department of Labor, or some of the consumer advocate. Next slide. And these are the links for the US HHS, Small Business Administration. This is why I gave you handouts. And the next slide, Insurance Department, HHS, and New Hampshire Health Plan. And hopefully that didn't confuse you at all. You could do it. So, and that's yours to take a look at.
I have a copy of the handout, and I know there weren't enough to go around, so if anyone wants copies, they can contact me. I'll take your name and email, or just at the next PAD meeting, about whatever mechanism you like. I'll make copies of this available to whoever asks me. And now, Carl?
Well, I'm going to start where the last speaker ended and describe my position as a navigator. I've been trained recently, passed 12 exams, spent 30 to 40 hours studying, and I continue to study their updates all the time. As a navigator, I'm trained to work with individuals, but also with small business. And that differentiates me from the other people. This gentleman mentioned they're called certified application counselors. We have them at Mid-State Health. I believe the hospital has them. I work right alongside those people. In practice, we do about the same thing. Only if there are issues that come up, and there are, everyone's different. Everyone's situation seems to be different with health insurance. I get those patients that need a little extra help, their complexities, and I work those out. We recently had Sally and Joyce over to Mid-State, and they've helped us, actually one of our first couple to come in, and they're helping us and we're helping them, and I think it's going well. As you know, if you try and get on healthcare.gov here, it started out very slow, and I just talked today, I checked in with them in the marketplace, and they say things are getting better. People are getting on and applying, and it's going better. They claim that they had many more people. You probably heard this on NPR. If you listen to NPR, you're pretty well informed. They had many more people enrolled, millions. They expected 100,000, millions went on. So I'm hoping in the next week or two, you can get on this site and go through the process within an hour or two. I'll also say before we get going here that I'm not a broker. In fact, sorry to turn my back on you, but Tyler could probably explain this better than I. Brokers are trained, extensive training. I have limited training, and I'm now working with brokers. If an individual wants to compare plans outside the marketplace, my role is to refer people to a broker, right? They have extensive training. So we all have roles to play. And so far, things are going well, I think. What I'd like to do tonight with you is take you through this website. This is healthcare.gov. How many people have been on this website? Would you raise your hand? Okay, great. My assignment for you is, I want to recruit everyone tonight. That's my purpose. I'm asking that everyone go to this site, and I encourage you to do what we're going to do in a minute. And I'm going to take you through something, and we may not get all the way through it, but you can go home and do the same thing. Okay? So I don't have any, I have a handout actually, but you can go back, get online, and do what we're going to do. So again, my job is to go out in the community and recruit people like yourselves to help other people. We've got appointments, our staff at Midstate, we were out, have appointments at libraries now, giving presentations, actually helping people enroll also. And I'm looking for your advice too on where we can go. Nonprofits, government, we're going to be out everywhere, mornings, evenings. I'm going to be up in North Woodstock, 7 o'clock in the morning next week to talk to Rotary. So we're everywhere. And if you have advice on where we can go to present, that would be great. So again, we're on this website. We're going to go to a place that at first I questioned. Here, I wasn't expecting much. Want to learn more first. I thought if I clicked that, they just show me documents, documents, documents. But actually, it's interactive. And so we'll see some of that right now. So would you please click on Want to Learn More. Start here. Pull that down. Okay, which best describes you? And when I'm talking, I'm going to be talking off what we're looking at. So that way, when you go home again, you'll be prepped a little. So one is I'm looking for coverage for myself or my family. The second is I'm looking for coverage for a small business or operate. The small business is known as SHOP. You mentioned SHOP. That's Small Business Options Plan. If you have less than 50 full-time equivalents, you can get into SHOP. If you have less than 25 full-time equivalents as a small business, you can get a tax credit. And actually, there's no penalty for small business. If they don't elect to offer coverage for small business, there isn't a penalty. There's penalties for individuals, and there's penalties for large business. And actually, for large business, there's no penalty this first year. Okay? So for tonight's purposes, we won't go to SHOP. We'll just go to the first one. I'm looking for coverage for myself and my family.
Could you step over on the other side?
Oh, sorry. All right.
Probably be the
That's-
slide.
that's-
She's asking to
Okay,
be
this
this
side?
side. Carl.
There you go, that's great. Okay.
Okay, what state do you want to live in? We know it's New Hampshire. And for tonight's purposes, I have something we'll choose, but let's look at under 30 first. I believe they have under 30 there because if you're under 30, you can elect to have catastrophic care. Much lower premium. A lot of the students here that we're in a college town, they may be interested in this because the premium is very low. But you have to be under 30 or there have to be other exceptions for you to get on that catastrophic plan. I'm hoping we chose 30 to 64. Can we go, I'm sorry, can we go back one? And we're going to choose 30 to 64. See, it's interactive, so that's good. So let's go. Okay, so we're going to choose one of these. And we're going to keep it simple. Because if you chose, I have health coverage through my employer or family member, it might mean that you need to go to your employer with a form and have them fill it out to say, hey, this is your coverage, and they have there's something to fill out there. And I actually have the form with me, and I'll share it with you later. It's something that we want people to bring to their employer and bring back to us so that we can help them apply. So for tonight, let's choose I don't have health insurance. All right. Okay, the next question, I'm eligible for insurance through my employer or a family member, or I'm not eligible for insurance through my employer or family. Let's choose I'm not. And we'll click next. Okay, this next slide, you want information here. Now this is nice because they're not giving you 10 chapters. They're saying, what do you want to know here? I'm going to say 18 years old, that's an important age. Under 18, under 18, you're required to have dental. And so that's something. If you have kids, you may be selecting a Blue Cross plan that has dental embedded in it. If you're older than 18, you can elect to choose a dental plan. There are 3 dental organizations in the state, and you could choose that. So I just thought I'd bring that up with dental, because that's important for some people, right? Okay, and dental coverage often is not cheap, right, compared to going into the dentist. So for tonight's purposes, we're not going to choose, thank you for doing that, but we won't choose, we'll just choose low-income coverage options. Because at Midstate, the mission of Midstate is to get out in the community and serve those that don't have insurance and actually go out there and find those people. I have a background in healthcare, and that's not usually what we did. We didn't go out finding people who couldn't afford healthcare. And I would add that at Midstate, their quality has been rated very high. So I'm amazed to find that they have excellent business practices and excellent outreach in the community. So I guess I have to say I haven't seen that to this extent anywhere. And I've been out in Oregon and New Hampshire. So we can pull down a little bit. There's pre-existing conditions. I don't know if anyone mentioned it, maybe you did. You don't have to worry about that anymore. You can get on with a pre-existing, like depression or diabetes. We're seeing people in the clinic with diabetes. Don't have to worry about it. The premium's not higher. It's amazing. So let's go next.
Do you have to check that?
Pardon me?
Do you have to check it?
Now here, yes, you do have to check it. We're going to say, let's say no. Thank you very much. Next, yeah. Thanks. It's a team event. And that, I guess in healthcare, we're supposed to work together, so it's a team event. Let's see what we have here, and I'll catch up with you. There's various information here you can choose, and if you want more information, you click on it. And there's something I want to highlight on this page. Okay. This first, let me just check where I am. Okay. I'll just mention here something that comes out preventive services. I don't know if that was mentioned. You know that if you're on one of these plans, you have that provided at no cost. You can go in and be seen, and that's a great deal. That's not very common. So let's go on and we'll go to the next slide, the next piece. Okay, we'll go back up. Let's go back up. I'm going to click on something here. Just give me 1 minute. And I'll find where you are. We're going to go to a hypertext in just 1 minute. Okay. If you just scroll down just a little bit, or scroll up. I'm going to get down here. Okay, here's the important point where we're going to go now. We could choose lower costs here or see plans. What I'd like to do first is explore lower costs, and then later we're going to come back and explore plans. Okay? Right? So let's first click on lower costs. Okay. All right, so under lower costs, you see pay lower cost premiums each month. There's an advanced premium tax credit that was mentioned earlier. If you qualify, and that is if you earn less than 400% of the poverty level, you can qualify to get a tax credit which will be applied directly to your premium. And I can give you the figures for what that is for an individual or a family of 4. For an individual, that goes up to like $44,000. So a lot of people can qualify for this advanced tax credit. So there's also an additional advantage that you can get if you're less than 250% of the federal poverty level. You can get additional cost reduction. It's called a cost sharing reduction. And that gets applied to your deductible, your co-insurance, and your copay. So there are people that are maybe getting close to 150%, say, of the federal poverty level. They will get advantage of both the tax credit and the cost sharing reduction so that their premium can be very low. As President Obama said, many people will pay equivalent to a cell phone bill a month. And I'm finding that, he said that, and I'm seeing, if you go online, and you can check for yourself, that for many people that's going to be the case. Okay. Let's pull down a little bit. Here are the figures for individuals. That tax credit, I'm referring to the tax credit only. I mentioned $45,000. For a family of 4, you could make up to $94,000 for a family of 4 and get that tax credit. Now, if you want to get that additional, if you want to get the additional cost reduction, and I'm asking you maybe to share this with other people, if you're less than 250% of the poverty level and you choose the silver plan, there are different plans, gold, silver, bronze. You have to choose a silver plan to get the additional cost reductions. So that's maybe more than you want to know now, but I'm telling you that because you may have someone that may be in need, and you could let them know, yeah, if you really want all the reductions, you want a silver plan at Blue Cross. Am I right? Yeah. So this does get more involved, and that's maybe the reason why we have navigators and certified application specialists. We're not brokers, but there's quite a bit to go through here. And so, again, my role is to explain this, but also actually help people enroll like we're doing now. We're just practicing now, but we could also go online and apply them. Okay? So at this point, let's go back, and we're going to choose the other option that we had. So we're going to go back. You could probably go back here. I think we're going to go back one more.
I think we're right there.
Okay. We are. See plans right here. Thank you very much. We're going to go here. Okay, which best describes you? I'm looking for coverage for myself and family. Let's go with that one. Keep it simple. We're going to have to click through here a couple times. Here's where you can, if you want to look at dental, you can, but we're going to click health just to keep it simple. Let's go on. Select a state. New Hampshire. County. Grafton. Next. Okay, will you apply for health coverage, or we'll choose only you? Okay, how old are you? We'll say under 49. That would be a lot. Okay, next. Okay, here it's showing the benefits, coverage, doctor visits, prescription drugs, hospitalization, preventive care. That's in all of these Blue Cross plans, right? Okay, let's hit next. Here, that's again to get your tax reduction over here. We already covered that. But let's look at this. Just pull down a little bit. Okay. Some people with lower incomes will save money out of pocket costs. That's what I mentioned before. If you're under 250% of the poverty line, you get these additional cost reductions on your deductible, copay, and co-insurance. So that's important to know. So let's hit next. These are the plans. The metal plan says bronze, silver, gold, platinum. There's no platinum in New Hampshire, right? We don't have a platinum. That's really would be more expensive premium, better coverage. I don't know why we don't. Not time to go over that. Let's look at that and move on to next. Okay, we're going to go to the 11 health plans. Now let's pull down just a little bit. Okay, these are the plans that come up to us. we entered that information, right? So this software program will tell us, based on what our needs are, right? What our needs are. So you'll see that the catastrophic plan is pretty low, $157. Now, you basically have to pay out of pocket up to your deductible, maybe $5,000 or $6,000, but you don't go broke, you don't maybe go bankrupt. So this plan really is significant for some people, right? Yeah. I'm going to show you something interesting I learned today, just to give you one example of the fact that I'm learning, because we're all learning about this. I think we are. Okay, so let's pull, I'm going to pull down, I'm going to show you something I haven't seen before. It's called an interstate plan, and I only found it today. Let's pull up slowly, and I'll find it. Let's go up this way, let's keep going. There's multi-state, okay? Didn't know about it. I was convinced after talking to Blue Cross that we only covered New Hampshire. Like, they're all HMOs, all bronze, silver, gold. So I was ready to tell people, well, I don't know what you're going to do if you go out of state. Talk to a broker. I was going to say, you got to see a broker because we don't cover that area. So today I see this, and I called Blue Cross Blue Shield, and someone's going to get back to me. But then I called the marketplace. I have a number, an 800 number, and I could get you an 800 number too. It's on this website. So I called in and said, "What is that?" And they said on their part it was new, but they could read me some information about it. Apparently, the multi-state plan is for someone that may be working in Boston. So you're here in New Hampshire, you work in Boston, and so you have to check your insurance to see is that the coverage. Now, Blue Cross, probably every state in the country, I don't know.
Yeah, the multi-state plan, as it turns out, is really still local. I mean, if you're out of state and you want to access providers, if you're on an emergency basis, you're fine.
Right.
Otherwise, you should go back to Blue Cross and make sure you got permission to do that. The idea of the multi-state plan was really a compromise. It's because there was no public option. So it's a product that's not regulated in the traditional sense as everything else sold in New Hampshire. And it was supposed to have some advantages in terms of being able to sell across state lines and things. As it turns out, what Anthem did is because WellPoint is a large national company, they just took one of their products that was going to be local Blue Cross and called it their multi-state plan. So effectively, it's very similar to what you would buy as a non-multi-state plan. That doesn't mean we won't see other national companies as multi-state plans operating in the next few years on the exchange in New Hampshire. But as it turns out, it really doesn't make that much difference.
I'm sorry to hear that, because the reason I'm following this up is I had a question. I had a client coming in that is going to go to Washington, D.C. for 6 months every other year. And so I researched this today, and it's maybe a little new. I should have talked to you first. But what I'm told from, and I checked this with the marketplace, the intent would be, as I mentioned, if you're working out of state, you'd be covered. And then also, if your primary residence was here and you live somewhere else for the summer, that you'd be covered too.
Yeah.
So the multi-state plan, it's important for us to know here, the multi-state plan is not really multi-state in New Hampshire.
Not New Hampshire's, no. The idea was it was supposed to be essentially regulated by OPM. It was supposed to have rules that were same across state borders. And the concern was, well, gee, would that give one of these companies an advantage over the local companies in the state? So, I mean, as it's worked out, at least for the short term, is Anthem's multi-state plan is nothing terribly unique. That may change over the next couple of years.
Couple of years?
It's hard to say because there's a requirement for these multi-state companies to be in every state or most of the states by 2016.
So that leaves me back with talking to brokers again. So if I have someone in that situation that needs coverage in Boston, I'm back to where I was yesterday, which is to say you need to see a broker to get that coverage for you.
Yeah, I mean, I would, for that person's circumstance, I would contact Anthem and describe their circumstance, because if they're working there, if it's more concerned about injury there, then Anthem may put in provisions. But it's, again, you're facing that narrow network, so they're going to try and keep you in the narrow network in New Hampshire.
Okay, and then if there is an emergency, if we're here in New Hampshire, you go to Maine, we are covered on all these plans. You're covered for emergency. emergency services. Okay, so tonight my goal was to get everyone on this website so you can see how you can use it, but you could also show someone else in your family or in the community how to get on and use that. And this is before even getting on to apply. And when you finally get on to apply, I think as you guys would say, it's fairly straightforward. And I would add that at Midstate, we're actually asking people, if you do come in to see us or send someone in, we'd like you to bring in information. We have a few things that we'd like you to bring in, financial information and some information about your household. So I have this as a handout if you're interested in it. I also have the employer tool. So if you need to go to your employer, this is the form you bring in. So with that, I conclude. Thank you.
So to paraphrase one of the speakers, I guess we're all experts now. I will open the floor for discussion and questions. Please raise your hand and I'll recognize you. You, sir.
I now have two questions.
Start with one.
One for Carl. When you say family, does that include people that just live together?
Oh, I can respond to that. And actually, I'm going to refer to one of my handouts here. Because that was one of the key questions I had at the very beginning. They say household. What is a household? So I'm going to read you, and actually, I communicate with the Centers for Medicaid and Medicare Services. I actually have the email address and phone number of the lead navigator for the country, and I've been communicating with her initially because things are changing and I want to stay current, so I have a direct line there. So I'm going to read what she emailed me this, and it is in our standard operating procedures. So yourself, okay, number one, yourself, your spouse, your children under 21 who live with you, your unmarried partner who needs health coverage, anyone you include on your tax return, even if they don't live with you, anyone else under 21 who you take care of and lives with you. So I really wanted to know, I wouldn't have guessed that anyone else under 21 who you take care of and lives with you, I wouldn't have thought that would be in your household, right? Would you? Yeah. So my job is to go out and research this stuff so that I can share it with people, because I don't think any one of us would come up with that list necessarily. And I think what they're trying to do is cover people, provide coverage for as many people as they can, right?
Well, the person that asked me about it said that he lives with his girlfriend, or they live together.
Mm-hmm.
She has coverage on her job, and he was looking for coverage. And he told me that he thought that when he went on the site,
Right.
that he had to use some type of family plan. It's kind of strange. I didn't understand what he was saying. But that's why I brought it up. Because
Okay.
I wanted to tell him about it.
Okay, so the girlfriend and the daughter, okay, are they covered?
I don't know if there is a daughter.
Okay. Well,
There's a guy and his girlfriend, and they live together.
right,
She has coverage on her job.
right,
He's looking for coverage on the Affordable Care Act.
okay,
I think he's going to have to go on his own to the exchange.
Pardon?
I think he's going to have to go on his own to the exchange in the marketplace. If it's just a boyfriend-girlfriend, I don't think it's going to be enough to...
Oh, because he was under the impression that somehow or the other they had to combine.
yeah, I have your unmarried partner who needs health coverage.
Unmarried partners covered.
Right, okay.
I'm sorry.
Yeah, no, I'm fine.
But the employer would decide whether or not they would recognize it. I mean, it depends which way they're trying to go. If he's trying to get on her coverage or she's trying to get on his coverage with individual policy, it could mean different things.
Oh.
I mean, but it's okay if they're on separate coverage. I mean, I don't think it
How would
matters.
he find out what the best thing for him to do?
Start by talking to the navigator.
Okay, we can, but I can add something to this talk, or you can send them in. Basically, it's not up for us to decide eligibility. What you'll do is, when you put your application in, the government's going to decide eligibility. They're going to kick it back. If it doesn't meet their standards, you won't be eligible. So how you apply, you're going to put the information that's best to your knowledge in, and you get a determination email back or mail back saying whether you're eligible and then what your tax credits would be. So that's where I step away. I can't know everyone's circumstance. I don't know for sure if this is that happening or whatever. When the person, in fact, I don't even enter the information. I'm supposed to allow the consumer to enter the information. And based on that information, the government will say, hey, this is the way things are going to be in terms of meeting their requirements.
So it may depend on how he enters the information.
Well, have them come in, like you was saying, refer them to me or one of the people at the hospital, and they can go in and get assistance right there.
Yeah, the question is, we need to be perfectly clear about their circumstances and what's being offered through her employer.
Yeah, well, I'm not sure either. I just know what he told me.
Yeah.
Next.
Can I ask my original question?
You have that wasn't your original question.
No, that was not my original question.
All right, let's have
My
your next.
original
Go ahead.
question was from Michelle.
Go ahead.
You had mentioned that the doctors, when you get referrals to different doctors, that it would be combined on one bill, or they would all charge
No, I was
together?
talking about information exchange, so that would be clinical information. So, for example, if you're say, a patient of mid-state, you've seen the physician there, and they've sent you to the hospital for certain testing.
Right.
That information will now be electronically transferred into their electronic medical records, so that next time you see the physician, they'll have all that information in one place.
I thought you said that the cost was shared between the doctors.
Oh, under the bundled payment pilot program, that's just a thing that they're testing nationally. And not everybody's doing it. You had to volunteer to participate in one of those pilot projects. We're not participating in bundled payment. I'm not sure of anybody in New Hampshire doing the bundled payment pilot program. But there are some in the country that are doing that, where they're sharing that payment.
But that,
What would be the incentive for a doctor to see a patient if his fee was going to be divided up among the other doctors if the patient is short?
Well, that's probably why they don't have a whole lot of people participating in that pilot. But the federal government wanted to give another option for providers to come together and work together to collaborate and coordinate care in a better manner. Because right now we all operate in silos, and this was really giving them an incentive to work together. Most have picked, if they're going to do a pilot program or demonstration, they're doing the ACOs.
am I right in understanding the bundling payment is the payment that returns money to the providers, the collection of providers, and it's not the bill that goes to the patient? That's a separate.
Right.
And it should provide the incentive for you to use resources more efficiently, so that the physician doesn't get paid more for every service they do. At the same time, they don't get paid less if they treat the patient more efficiently.
Okay, thank you.
I'm concerned about paperwork. Being a Medicare patient and receiving 4 pages a month for my pharmaceutical of $5.20 and other considerations for my medical care, and probably 8 bills from Mid-State recently for kooky little tests. What is happening under the ACA that is going to prevent this barrage of paperwork being received by customers? Is there going to be a way for a person to just receive it online rather than as paper? I have mymedicare.gov. It doesn't make a bit of difference. I still get all this stuff in the mail, and I talk to the lady about it all the time. Of course, she can't do anything about it, but is there going to be a way to minimize paperwork for customers who enroll in the state health care plan?
I'm not aware of anything in Medicare that's going to reduce the paperwork
No,
that you're going to
but
get
what
back.
about this plan?
For the market, well, the marketplace is not for people in Medicare, so.
No, I understand that, but are they going to give Raj with the same number of sheets of paper?
I would say probably.
They could get it and print it out themselves.
Well, you're probably right. I'm not sure that these folks.
Well, I
can
just
do
want
it.
to be an area.
Okay. I'll consider the new clerk.
This is a question for Carl. As you were filling out that form and making choices, and you came up eventually up to a monthly premium, that was a monthly premium that was quoted without factoring in the tax credit,
That's correct.
because that would be, throughout this process, that would be applied.
There is a calculator, there's a Kaiser calculator on this website that you can go in and enter your income in, and it will estimate approximately what you pay for a premium after the tax credit. Right now, Blue Cross, if you went on the Blue Cross site, they have a calculator. Currently, it's the Kaiser calculator, but in the next couple of weeks, Blue Cross is hoping to come up with their own calculator. Is that right? Yeah.
Are there other questions? Yes, ma'am.
What happens if you move to another state? Do you have to go to their exchange and get insurance again?
Yeah.
Now, does that also affect the very common practice we have in New Hampshire of snowbirds? You spend 4 months out of state. We run into a lot of complications and problems with our mother who is out of state for 4 months out of the year.
Remember, Medicare, though, if they're Medicare, they're not, there's not subject to the requirement.
Right, but if it's Medicare, it's a huge issue. There's only allowed one residence. So if you have to spend 4 months out and 4 months back, I'm wondering with this, if there's the same thing. I mean, if you happen to be fortunate enough to be 62 and spending 4 months down south.
Yeah, the state border issue is there. I mean, part of what creates it more, makes it more complicated is that some states, the states have their own exchanges and their own set of rules. So, I mean, they tried to create this as much as possible, the option for states to do something uniquely. I mean, you look at insurance as being regulated at the state level, they wanted to create some level of compromise, but with so many states going with the federal exchange, I mean, maybe there's some advantages, but you're still going to have situations where if you're employed out of state, how do you figure things out? And of course, if your employer doesn't offer coverage, then you have a choice perhaps, or it's not always clear. Yeah.
I mean, somewhat related to that Carl question in regards to not everybody has Medicare Part A. A majority of them have access to Medicare Part A. So if you don't get into the exchange,
What was the question? Say it again, please.
not everybody over 65 can access Medicare Part A. Right. It's a small number, but not everybody can. So I was asking whether they can get into the exchange.
And to purchase Part A, this is a Medicare question, I'm hearing that you don't have to do anything, this is an important topic actually, you don't have to do anything in terms of marketplace if you have Medicare. And I've learned that there's actually two ways to get into Medicare. One is free Part A, where you've been paying payroll taxes quarterly, and then you also, if you don't qualify for that, you can pay for Part A, and it's like $443 to pay. And I'm investigating now because, and again, I'm sharing too much, but I'm investigating, I have a question later, as to whether those people who don't have access to free Part A can get in the marketplace. And I'm currently investigating that because I've seen information to say that that's the case from my literature of standard operating procedure, but this isn't the place to research it.
Yeah, it's because the insurance markets are dependent on having people within a certain age range, essentially. I mean, if you start allowing people beyond 65, all the underwriting assumptions go out the window. So they've got to allow a certain amount of protection to the private insurers from people who are beyond the age expectations. That's one of the main reasons. So the other assumption is that there are options for people above 65 that don't need to end up in the commercial market for the rest of us.
Yes, ma'am.
First, I just want to thank Carl because I have to go on and do this like soon, and I was dreading it, but having gone just through it, it looks really simple to me. So thank you so much for doing that. And I'm just going to back out and talk about healthcare reform in general. Listening to everybody over the last few weeks, it feels like this Obamacare thing, this health exchange thing, it's just a tiny little tweaking around the edges, am I not right? And some of the changes that are happening in healthcare are some things that Michelle has been describing, which is coordinated patient records and that in cooperative arrangements between healthcare providers and that kind of thing. So, is that the correct sort of impression that I'm getting, number one? And number two, it sounds to me like what will happen down the road if we continue down this path is that this exchange marketplace will become very competitive, and therefore there'll be more and more incentive for more and more people to get into it. And what we may be doing is taking away the incentive for employer-based coverage and having more and more people just go to this model. Is that true? And if it is true, is that a good thing in your estimation?
Yeah. What you said is true. I mean, it is a small segment of the population. That's why I start there with the presentation. So, but despite the fact that exchange and the individual mandate got huge amounts of attention in the media, it really is for a relatively small portion of the population. I mean, still, you're talking 100,000 people. It's 100,000 people, but nevertheless, the incentive, yes, for employers to take a second look at whether or not they need to offer coverage or tell people if they're going to be better off buying it through the exchange or the marketplace. Yes, that potentially will happen. There are some folks that would like to see it happen. Some people think that having your health insurance tied to your employer status is inappropriate. We should be buying it separate from our employer avenue. Whether or not it's a good thing, my concerns are, as a regulator, looking at our insurance pools and having a certain amount of stability among the different markets. Anytime you have people exiting a certain market, they're usually the healthy people, or they're people that can access something better someplace else, which tends to leave the sicker or the otherwise disadvantaged populations in whatever pool that's left over. So I think to the extent we focus on that small group market, which historically has been a heavily regulated market because small employers are in such a tough situation, there are a lot of protections there. If we start to lose people from that small employer market, I think that's a concern. Not only could we lose them to the individual market and the exchange, we could see some of those larger small employers say, I've got a healthy population. I don't want to be subject to all these ACA requirements or the premiums that include all of these other people in my pool. I'm going to go self-fund it and take advantage, take my chances. That's another possibility. So I think to the extent that we look at the insurance markets and regulation, what's good or bad, most of us would like to see some level of stability, but I think that there are some folks, some policymakers that would like to see small employers push their employees into the marketplace.
I believe Vermont did that.
What was the question?
I believe Vermont is forcing all the small employer individual market through their exchange.
Well, I think they're encouraging their small employers to buy it through the exchange, but I'm not sure that they're saying buy it on your own as an individual through the exchange. So there is the incentive, as I mentioned, the tax credits for small employers to buy their insurance through the exchange. If they buy their insurance outside the exchange, they can't get access to the same tax credits. But the other piece, and I don't want to add too much information, is that the way a small employer will buy their insurance through this shop, this exchange, is they're going to see the individual premiums for everybody, which is a change from history where small employers tend to see a composite rating. So in other words, they saw an average premium for all their employees as they receive their premiums. And that's going to change going forward. So they're going to see how much more expensive older people are as employees because they're going to have the option to go to the shop and really have people choose which products they want as a small employer through the shop. And the only way to kind of keep the billing in sync is to make it on an individual basis. So some people are concerned that, well, gee, even with a floor and a ceiling of 3 to 1, which is the most your premiums can vary for people based on age, that means 3 times as much will be associated with somebody who's older versus somebody who's younger, that's not necessarily a good thing from a public policy perspective. The other way of looking at it is if you actually look at the claims cost of people through that age range from your single digits up through 60, the difference is more like 6 times. So if you've got a floor and a ceiling of 3 to 1, the actual is 6 to 1, and that means you've got a level of subsidization between the younger, healthier people and the older, sicker people. So it's, depending on your perspective, it's either a good or bad.
But isn't insurance by definition a level of subsidy of those
exactly
with lower risk to those with higher risk?
Right.
And then you get old, like me, and you become what you didn't like when you were younger.
Yeah.
More useful questions, yes.
Question, since the whole idea is preventive care, do even the lower plans, do
they mandate certain things that are really absolute for saving lives, for like free mammograms?
No cost sharing on preventive
and
care
every
services. Right.
Yearly checkups?
Yep, no cost sharing on those preventive care services. That's a change with the ACA.
Jim, was there, yes, ma'am?
Question. I tried to save my kid a couple of times today, and he's in a private plan, so I'm a private plan, and I thought we could go to the exchange. He lives in Durham, and Concord Hospital's not on it, Portsmouth Hospital's not on it. But, so I was discouraged actually, and said just have him stay on the private plan.
Yeah. It is certainly a choice that's worth making. The other thing to remember is often in cases, even when the hospital is not in the network, there may be physicians in the community that are accessible. For example, Concord Hospital is not in, but Dartmouth-Hitchcock has a strong presence in Concord. The other way of thinking about it is you're looking at hospital services. And, well, is it really that big a deal for them to travel from Concord to Manchester? I mean, it's 20 minutes. I drive from Nashua to Concord every day for work. Just to keep things in perspective,
So he would find a PCP in the network that he could go see and it'd be free for yearly
checkups.
Which is not with the private, it costs money.
Well, depending on what coverage you have, would it be under your coverage?
Really, no, it's his own thing. Like I said, a really high deductible and it's really expensive. So it might actually.
Well, all the plans that he may be under already, they have to be ACA compliant. So they would, I mean, they have to follow a certain set of rules for preventive care services and some of the other cost sharing. So that may be changing as well.
Are you able to stay for a few minutes? I think the hour is getting late. If those who have particular issues and may wish to talk with our guests, they'll be here for a few minutes. Otherwise, please give me a